The speaker is Anssi Peräkylä, who is an academy professor at the Faculty of Social Sciences, University of Helsinki. So since his PhD at the University of London in 1992, he has investigated clinical and everyday social encounters using mostly conversation analysis as a method. So the setting he has investigated include AIDS counseling, primary care medical consultations, psychotherapy and psychiatric assessment interviews. In his recent work, he has combined conversation analysis with psychophysiological methods, part of that we have done together, and since 2019 he has been engaged in a project focusing on the experience of self in social interaction. So this project seeks to combine Erving Goffman's sociology of self and clinical and personality psychological conceptualization of narcissism.
I will continue talking about the evaluative perspective to self, and in this case, I'm looking at very specific interactions. I'm not looking at populations. I'm looking at 3 individuals. But what is happening and how I'm analyzing these interactions involves exactly that kind of a third-person perspective to self that Professor Rocha was talking about. So this is about psychiatric interviews with personality disorders. Personality disorders involve trouble with self-experience. In a study that I'm involved with, I'm investigating how the patient's self-experience is dealt with in the assessment interview when the interviewee has or will be diagnosed as having personality disorder. The data comes from a psychiatric outpatient clinic in southern Finland, and as I said, I have investigated 3 patients, their full assessment processes, which altogether consist of 21 interviews. So, social evaluation and self-experience. As Philip pointed out, in classical social psychology, there's a strong tenet of seeing self-experience as something that arises from my perception of the other's perception of me. Charles Horton Cooley encapsulated this in the idea of looking glass self, and Philip Rocha has been in this context talking about first and third person perspective to the self and the kind of inherent tension between them. Between those. First person perspective was this perspective which is developmentally earlier, it's anchored in the integrity and agency of the body, and the third person perspective is anchored in this moral space, and it incorporates the other's gaze. And as Philip points out in his point, our life involves attempts to reconcile the first and third person perspectives through self-presentation. These attempts are never so successful, though. Erving Goffman wrote in 1961, I think, the book was published in 1963, the famous book Stigma. And it was about how something that belongs to the individual can spoil the identity of the person. In ancient Greece, stigma was referring to cut or burnt signs indicating that the bearer is a slave, criminal or traitor, and something to be avoided. Goffman pointed out that something like that, a process like that, is happening in our society too. He said that there are 3 types of stigma. Stigmas having to do with body, problems with the body, deformations of the body, problems with the character, and issues having to do with ethnicity and tribe. The world is different now from 1963, but these things still exist, I believe, and I will be looking at the stigma related to character. Goffman also pointed out that there are 3 strategies for the management of stigma. for the stigmatized person. One is that as the stigmatized person, I show that I support the norm, which in a way condemns me. I acknowledge my failure to meet the norm. The other one is to alienate myself from the community that supports the norm, somehow to reject the norm that defines me as stigmatized. And the third one is the information control and collaborative impression management, of which Goffman made sort of ingenious observations. I should say that in Goffman's treatise, these strategies are something like life strategies. I will be showing these same strategies on the level of second to second unfolding of social interaction. Now, character as a stigma. Goffman's term was blemishes of character, and I would like to argue, and I think my data show, that impulsive behaviors are treated as stigmatizing character feature. They are also a key symptom of personality disorders, and the interviews that I'm looking at are indeed about the description and reports of impulsive characters. And what I'm investigating is that how do the patients and the clinicians manage the self-related, stigma-related implications of the talk about impulsivity. I will now show extracts only from one of my three cases, as it were. Let's call her Milla. She's a woman in her early 20s, in vocational training, was referred by the school psychologist because of anxiety, self-harming behaviors and impulsivity. And now we will be looking at how Milla relates to her own behaviors and relates to the self that emerges from those behavioral reports. And I'll show three stances in Milla's relation to her impulsive behaviors. One is self-reproach, the other one is lessening of the reproach, and the third one is defying the reproach. And these three stances, I will argue, correspond to Goffman's three strategies in stigma management. Asserting the norm, showing that I'm not fulfilling the norm, or negotiating the impression that I make, or distancing myself from the norm. Now, to get the understanding or feeling of what kind of interactions these are, here's a segment of an interview done by the psychiatric nurse. She's interviewing Milla. Milla has admitted that she behaves in impulsive ways, and now the psychiatric nurse asks her to describe this in more detail. So the first of these three stances that Milla takes towards her own behaviors is self-reproach, reproaching herself for what she does, how she behaves, and the self-reproach can take three practices, assessments, what we call extreme case formulations and gestural displays of negative stance. Let's look at assessments. This is from the interview that we just heard. She was saying that I have a bad habit of throwing things, objects, and then she at the end of the segment she said that she doesn't hit the target, the other person, which is really good. So she sort of inserts this assessment into the description of the behaviors, negative and positive assessments, which adopt the perspective of another, of an evaluating other. This is actually from another interview from the second patient, but I'll just show it briefly. She describes her way of getting angry at her colleagues and friends and saying, I myself get annoyed too when I'm nervy. I might say really bad things even like to my friends. Again, there are elements through which she takes another person's perspective, assessing perspective to her behaviors. Then another practice of self-reproach involves what we call extreme case formulations. This is from Milla's interview. She was saying, also I'm still getting offended really easily, making it totally strange, something like totally strange from something that the other person says to me, something totally like something that she has like not even hinted to, anything like that. She emphasizes her descriptions of her behaviors. She produces them in the dramatized language. It's interesting that in earlier research this kind of a practice of extreme case formulations has been identified in actions where the self is, as it were, defending itself against the others. But in this case, the self is somehow reproaching herself through these extreme case formulations. Here's another example. The nurse was asking what is the bad day in your case. Milla had told that she has had bad days, and then she said, I've just been snapping at everybody, and she continues, just been snapping at everybody, been irritated at everything. Again, kind of an exaggeration of the behavior which conveys this third person perspective, others evaluative case, which is reproaching Milla for her behaviors. Then we have bodily displays of negative stance. When Milla was telling about this snapping at everybody, being irritated by everything, she made a pause in her talk, discontinued it, and then during that pause, which is here in line 17, she was shaking her head and continued shaking her head for quite a while, and then continued with this kind of a summary, quite like that. we see here this moment as a anonymized picture. Again, the headshake was conveying a negative stance to Milla's own behaviors, and it occurred when the progression of her speaking was halted. We can hear this moment of the talk, and I will show I showed whether it is in the pause during which the headshake took place. Okay, so self-reproach in the reports of the impulsive behaviors, done through evaluation, trying to extreme case formulations, done through gestural displays of negative stance, such as headshakes. Thereby, the evaluative third-person perspective is invoked and emphasized, and in Goffman's terms, the patient shows that she belongs to the community that upholds the norm. She recognizes the norm and orients to her behavior in terms of that norm. Now there's this other type of stance which involves what I call lessening of the reproach, which is done by showing through these descriptions that despite of my impulsive behaviors, I'm still acting responsibly, or it can be done by attributing the blame to the others. And now let's just look at an example of the first one, display of residual responsibility. When Milla was telling about these bad days and about snapping, she said, so I've just been snapping at everybody except of course at work. It's not been possible. It's been necessary to keep that like separate as like in private life I've just been snapping. So it's showing that alongside the impulsive behaviors, she in the like significant relevant environments acts in responsible ways. By lessening the reproach, again the patient maintains the evaluative third-person perspective on the self, but she negotiates the value of the self, brings up about the self something which is not reproachable, kind of an aspect of it which is not reproachable, but it is responsible in this case. And then the third stance has to do is what we might call the contrastive stance display. The nurse was asking that what happened when Milla last time was involved in self-harming behaviors. What happened then? What did you do? How did you harm yourself? And then Milla answers that there's a moment of sort of difficulty to understand that, but then they understand each other's, and Milla answers, no, it isn't. Saver in hand, and off we go. So to say, meaning I cut myself. And what I'm interested here in is the word choice, the prosody, and the facial expression of Milla when she describes this action of cutting herself. The word choice, shaver in hand and off we go, is a kind of a light. You associate that with something happy happening. So off we go to the holiday, or off we go somewhere else in a happy way. She says this in a kind of a light. On one hand light, on the other hand sort of no problem prosody, savory käteen menoksi, or something like that. I'm not really good in music, cannot completely sort of reproduce that, but it's certainly not a serious prosody. And importantly, while she says this, she smiles. These are anonymized sort of reproductions of the facial expression. Having said shaver in hand and off we go, she starts smiling, first looking at the nurse who is asking the questions, and then looking a little bit away from her. And the smile when she's looking at the nurse is a little bit like restrained, and when she's looking away from the nurse, it is quite wide. And importantly and interestingly, the nurse does not reciprocate the smile. I mean, we often reciprocate each other's smiles, but in this case, the nurse, as you can see, is quite sort of neutral and serious in her face, in spite of the smile. We will hear this once more. So by defying the reproach, by these contrastive stance displays, it appears that Milla and the other patients in my collection are momentarily resisting the third person evaluative perspective. And in Goffman's terms, they take this third strategy in dealing with the stigma. They alienate themselves from the community that upholds the norm. At this moment, with these interactional practices, they do not show that this norm, where these behaviors are treated as problematic in a way, is a concern for them, but they show a different relation to these behaviors. Now, to discuss these little observations, let's go first back to Goffman, the sociologist of the self. Goffman, through many books and texts using many different concepts, said that through our behaviors, through our social actions, we define ourself, what we are, our social self, but also our sort of self-experience and self-image. And he also pointed out that the other's behaviors in social interaction may confirm this self-definition, or may disconfirm that, and that creates a kind of a drama in everyday life. So, but in one text, he added something which is quite, I think, important in relation to this data that I've been showing to you. He wrote that in some of his minor gestures, about the actor, the social actor, some of his minor gestures will convey what he feels about having self that is defined in this way. So we define ourselves through our actions, in this case what we tell about ourselves, and this narration being in the interview, but through the minor gestures we can also convey what we feel about having a self that is defined in such a way. And these gestures do not mean only like physical gestures, they can also mean word choices and prosody and so on. And now I have shown some of such minor gestures where the actors conveyed what they felt, what was their stance towards the self that was somehow depicted through the reports of the impulsive behaviors. And Goffman continued, such gestures will be taken as part of his enacted self by himself and others, which fact can in turn be taken into consideration into the assessment he or others make of him. So that our ways of these minor gestures become like part of the self that we are enacting, and this is taken into account when we assess ourselves and when others assess us. And somehow for this reason the psychiatric interview seems to be a laboratory of the self, because this exactly is happening in the psychiatric interview in my data. The stance displays are there, and in their assessment of the patient, the clinicians take into account not only the reports of the impulsive behaviors, like what's happening outside the consultation room, but very much the assessment is attuned to how these behaviors were described in the interview, and I've shown to you like some of the ways how they are described. Then we should get further. About psychiatry, self and morality. Psychiatry is part of medical science, but as Jörg Bergman has pointed out, psychiatric interviews are thoroughly moral situations. They are not just about reporting facts, they are very much about moral evaluation. And while the clinicians in our data are relatively cautious in expressing moral evaluation, the patients display their self systematically and skillfully with an orientation of being morally assessed, as we have seen. And finally, back to stigma. Goffman, as I said, described 3 types of stigma management as life strategies. And I've shown that these strategies also reside in the second by second organization of interaction. Goffman's book in many ways reflects the cultural landscape of early 1960s. Many stigmas having to do with physical impairments or atypical development have lost their intensity, even though might not have disappeared. But stigma as a shadow of the self is still there, and if we sort of believe in Goffman, that's part of the social organization. It will not go away. And in psychiatric interviews, in those moments that I've shown to you, blemish of character, to use Goffman's terms, seems to be as stigmatizing now as it possibly was in Goffman's time. So thank you very much for your attention.